So first question is, how can you manage outpatient and inpatient care together? And how do you organize it? And in addition, does artificial intelligence help you to manage this interface better? And what are the most successful business models and most important key performance indicators in this area?
Yeah, thank you, Pierre. I think, the reality of outpatient and inpatient care in the US is very different from the reality that you all face in Germany. We don't have the regulatory barriers and firewalls imposed, preventing us from really integrating the care and the information sharing across the ambulatory space, the outpatient space, and the inpatient space. And so, for context, we have it easier. Okay, it's just the context that we live in makes it easier. And so, for us, doing that integration really has very little secret, in that we were lucky enough to, when we implemented our electronic health record, it was a three-way agreement between two medical groups, a very large multi subspecialty pediatric group with about 400 subspecialist pediatricians, and then another group of about 200 or so primary care pediatricians in the community and the hospital. And we actually approached our now EHR vendor, then it was our vendor to be, to say, hey, we want to do a four-way agreement with you. And the vendor looked at us and said, no, we don't do that. Pick who is our partner, and you figure it out with the others. But we set up basically a strategy of one patient, one record. So we're very lucky in San Diego because we're both the provider of choice, but also the safety net for pediatric care in the area. We take care of 90% of the kids in San Diego. And so this one patient, one record strategy made sense to us. So we have a single database, and we all share the same electronic health record. And the only pieces that we separate are the financial side of the house, right? So all the patient billing, all of the revenue cycle is separated. There are different service areas. But when it comes down to the clinical information, it's all in one record. And so that makes it easy to share. Now, we take care of patients who may be seen by other providers who are not on our EHR. And luckily, the US has a good interoperability implementation now. It wasn't that easy back in 2009 when we first went live, but by now, right, the vendor solutions talk to one another. We have information sharing infrastructure that makes it very easy for records to flow from one provider. It doesn't matter if it's a local provider. It can be somebody across the state. In some cases, it could be somebody across the world. And it doesn't matter whether they have the same EHR solution as we do. Everybody has the ability now to share information across. And so we get all kinds of data to be able to take care of those patients, whether it is immunization history or orders and results or labs or allergies, notes, radiology reports, images, you name it. And so it truly, there's a lot of work behind the scenes to make that happen, or there was a lot of work behind the scenes to make that happen. But it is relatively easy nowadays and seamless for our providers, right? But again, it's a very different environment, and I know that you're going to think I'm naive and crazy when I say this to you and propose this to you, but to get to that level of interoperability, and at some point, you're going to need to have your regulators rethink the law, right? There is this sense of, well, let's give the patient the ability to control where their record goes. And I think that is great. But when you think about the elderly, when you think about teenagers, when you think about, there are parts of the population who frankly don't want that. They just want to be taken care of, and they don't want to be managing information. They want their providers to manage it for them. And so somehow, kind of, yes, it's great that the patient has the control, but somehow there should be a way for the patient to give up that control if they wish to.
Yep. Thank you so much, Albert. So this is the information we want to achieve. Yeah. So again,
All right. So I didn't answer about
it comes.
KPIs and AI. So yeah, there is
The second question, Albert, do you see the second question? What is the best way to manage an emergency room effectively and cost efficiently, and which tools help you to manage performance?
Yes. So we rely heavily on data, right? Our clinical leadership in our emergency room have worked very closely with our chief data officer to develop a number of dashboards to help us run operations there. And so we do all kinds of things there, from enabling, providing patients with information before they make the decision to come to the emergency room, right? We have a symptom checker online on our website that allows the patient to interact with it and get a sense for how to best handle what they're dealing with. Is it better for them to go to their primary care doctor? Is it better for them to treat at home and monitor? Is it concerning enough that they should kind of get in the car and drive to the emergency room? Are they better off going to a closer urgent care center? Right. So we give them tools on our website to be able to make those decisions. We also run some predictive analytics to show waiting times, anticipating waiting times. And we have to be very careful in the US because even though many people in Europe thinks that in the US, if you don't have money, you don't get care, that is actually not true. And there is a law called EMTALA that requires every emergency room to treat and stabilize patients when they come in. And anything that we do that could be construed as diverting patients away puts the hospitals in serious legal risk. And so we all go to great lengths to make sure that everybody understands we're going to treat you no matter what, whether you're able to pay or not, etc. And so, so this was an interesting conversation with our lawyers and what have you before everybody felt comfortable that it was okay to publish wait times, because we didn't want them to be dissuasory and cause people not to come if they had a need for services. Right. We also allow patients to, just like in a restaurant, right? They can call ahead and get a place in line, if you will, and they can do that through our MyChart application on their computer or their mobile phone, right? And they can do all kinds of things there. We have great interoperability with the local ambulance services through an interface called Safer that allows us to ingest patient information as they're riding the ambulance, so that we're ready for them when they get to the emergency department. So we have lots of tools, but then we also provide kind of decision support that is embedded onto our EHR, and we constantly monitor flow dashboards that show us arrivals, left without being seen, census across the unit. We can see the patient flow and length of stay in the ED. We run some AI that helps us predict the likelihood that a patient is going to need to be admitted, so that our inpatient units are ready to take on those patients, so that they don't generate bottlenecks. We work together. So it's not just the ED, if you will. The tools that we have in place help us to connect with the rest of the health system to ensure kind of the best possible flow of patients. Yep. So that we can handle the capacity. Our emergency room was built in the 1990s, and it had, at the time, we were seeing 25,000 visits a day. It was built thinking that capacity was going to double to 50,000 patients a day. Not 50,000, a year. 50,000 patients a year. We're now seeing over 100,000 patients a year. So our capacity is way under what we need when that ED was built for 50,000. So we're building a new tower that's going to have a new emergency department, because at some point the physical space becomes the limitation to run an efficient operation.
Thank you so much. We come to the third question. Where does artificial intelligence help to improve administrative processes while contributing to employee satisfaction?
Yeah, so we have a number of artificial intelligence and RPA running in place, lots of it on our revenue cycle front, where we try to predict denials, and at some point this is going to become the nuclear arms race of AI, where we try to predict denials and the payers try to predict our predictive of denials, and anyway, it's an interesting concept. But we have a number of bots that work us to run pre-authorizations from insurance companies to be able to provide services. We do denials. We do claim status checks, all kinds of AI and RPA processes to make our revenue cycle more efficient. We have not, like, we do quite a bit of predictive AI. We have not done a ton of large language model type AI. That is something on our roadmap for the future, but we haven't spent a lot of time there. And in fact, the few AI that we employ there is all off the shelf vendor produced AI, commercial AI. But we have one that we call Kai that helps with recruitment, and it's allowed us to last year we were trying to up our par level of nurses, our core staffing for nurses, and we set out to recruit 300 nurses in a 3-month period. And historically, we had seen that getting everybody's schedules in place by the time we had somebody scheduled for interviews, etc., they had already taken another job, right? And with this chatbot, we're able to work that scheduling challenge in a matter of seconds, and then we can close the loop, get those interviews scheduled in a much shorter period from the time of application. And so we were able to hire 300 nurses in 3 months, which is was unheard of for us. So that is great. Of course, we also use AI to help us with accounts payable and ingesting and interpreting invoices, and then automatically generating GL entries, etc., to pay our vendors. We do a ton of job automation of IT jobs behind the scenes, etc. We use Juniper network AI assistant called Marvis that allows us to troubleshoot our wireless network, and has really been life-changing for the customer experience, because it alerts us, and depending on what it sees, it can either take action itself to readjust strength signal, etc., to ensure seamless experience, connectivity experience for our end users, or if needed, it alerts an engineer or a technician to deal with it. But it's dramatically reduced the number of calls related to wireless connectivity to our service desk. We have a number of AI tools. Some of them are consumer facing, some of them are more kind of professional facing. Some are clinical, some are non-clinical. If you don't mind, I'd like to show this chart. It's the Daniel Barchi chart. Daniel Barchi is the CIO at
you can share.
Yeah. Let me do that. Share screen.
Yeah, I know that. A good chart.
See that? All right. So this is the chart, and it's a chart that Daniel Barchi from Common Spirit first created to categorize the AI that they used at Common Spirit, and So now it's kind of become a thing. And so it's the bar cheat chart, but this is the bar cheat chart for rated children's. And these are the AI and RPA that are currently live at Rady Children's. You can see that some of it is done by us, some of it is done by our vendor partners, and there are a number of them. We are at this particular time, it's a little bit slanted more towards the non-clinical, right, the administrative, but I anticipate that as we all get more comfortable, we will see an uptake on the clinical space in the years to come.
Cool. Can you stop the screen sharing? Then I will
Yes.
show the last question of our talk.
You got it.
Mhm. Dun, dun, dun. Nein. Da unten. Here we go. Last question for our talk today. What are the next steps to integrate AI into patient care, and how do you train the models and employees? I think if you like, you can go back screen sharing, but this is our last question, Albert.
So that is the kind of $6 million question, right? Is how do you do this? Well, I think you do it carefully, right? AI has tremendous potential, but I also think that like any technology, there are parts of it that it's very new. And so while we have been using AI in natural language processing for decades, right? We've been using it in health, patient health records for forever. We haven't, we're only scratching the surface when it comes down to kind of true clinical care, right? Closer to the patient. And so I think the way you do it is you gotta be careful. You gotta kind of measure twice and cut once, if you will. And so the approach we've taken is we've established an AI advisory council that is multidisciplinary, and it's made up by technologists, it's made up by clinicians, it's got our clinical ethicist in it, and we've adopted a set of principles that call for us to make sure that the AI that we introduce is safe, right? That is free of bias. It's extendable, that it's transparent, right? So that patients know when we are utilizing AI. And at this time, there is a human component, right? The AI takes things to a certain point, but then a human does the validation to say, okay, does this make sense? Yes or no? And then it proceeds, right? But that approach of it's more augmented intelligence, if you will, that artificial intelligence, right? We still want a human in the middle. A time may come when we feel comfortable enough that we may not need a human in the middle for everything, but for the time being, we still want that human in the middle.
I say thank you so much. And Jürgen is now back, and he has a wonderful gift for you that we may can share next year. So now virtual, but next time maybe you can
With the flow.
hear it. So at our side on the world, we just have evening, and now we have come together with Jürgen from DMI, and so it was awesome to see you and to have this talk with you, and we wish you from the bottom of our heart a wonderful Christmas time.
Vielen Dank, Pierre and Jürgen. Happy holidays to you all, and looking forward to seeing you soon.
Take care, older brother. Bye-bye.
Bye-bye.
Cheers.